Hello, and welcome to another episode of the Lancet Pulse. I'm North American Clinical Acquisitions and Outreach Editor Matt Gilbert, and I'm joined today by my colleague Niall Boyce in the UK, and we're here to discuss Kratom or Kratom. Hi, Niall.
Hi, good to be on the podcast. So the first thing I think we decided is that we're going to pronounce it Kratom, but this is an area in which I'm not a lot of help because it's not really known about in the UK.
So as far as I understand, it has been officially illegal in the UK for about a decade. In the US, it is currently classified by the FDA as a chemical or drug not suitable for market or sale as a dietary supplement, and by the DEA as a drug or chemical of concern, but not illegal at the federal level, so still widely available. From what I understand, Kratom or Kratom, which is an English transliteration of local names for the leaves of the Mitragyna speciosa plant, which grows native in East Asia and has been chewed, brewed into tea, or smoked for its analgesic effect in traditional use for decades, if not centuries, but has become popular in the West in the last quarter century, in part in the U.S. on the back of the opioid epidemic. As our guest, Dr. Liza Hutchison, will explain, Kratom or Kratom works as a partial opioid agonist, and many opioid users have found it effective in mitigating withdrawal symptoms and managing chronic pain and for the many other uses of analgesics. Some users also report a stimulant effect. While this drug has been widely available, a new concentrated form known as 7-hydroxymitragynine has recently caused concerns of overdose and dependency and has drawn the attention of lawmakers across states and local legislatures in the U.S. So Liza, if you would please introduce yourself and then help us begin to get a better handle on this potentially dangerous but inexplicably freely accessible drug.
Absolutely. Happy to be here. So I'm Liza Hutchison, and I am a family physician and addiction medicine physician. And I'll take a moment to sort of explain my different roles because I think it will help understand the various perspectives I have on Kratom and 7-OH. So I'm an assistant professor of family medicine at the University of Michigan. And then also I am an addiction medicine physician, and I oversee addiction medicine services at a local federally qualified health center here in Washtenaw County in Michigan. So I'm sort of in the academic environment, doing a lot of training, teaching, education, also in the direct care environment in that federally qualified health center. And I also oversee a statewide telehealth on-demand buprenorphine service, which offers care to people seeking help with opioid use disorder. And that is another area where we're seeing Kratom pop up, and I'll talk more to that as we go. And I think just the other piece that is important about my identity is being both a family physician and addiction medicine physician. I'm really seeing the combination of, my family medicine practice. I'm seeing people who tend to be able to use this product to ease some of the symptoms we'll talk about, right? Chronic pain, mood problems, things that we see in primary care. And then also in my addiction medicine practice, I'm seeing a lot of the risks and the dangers of people becoming addicted to these products. So I sort of have that dual lens that we can talk about more as we go.
So this is really interesting, Liza, because, clearly, the UK and the US, we had a bit of a misunderstanding, I think, 250 years ago, something to do with tea. So now we have quite different political and legal systems. And in the UK, I know about a decade ago, there was a lot of concern about what were called novel psychoactive substances, things which were being sold as dietary supplements or as bath salts. And this act was brought in, the Psychoactive Substances Act, which effectively means that Kratom isn't known much about here. There aren't many statistics on it. I looked up Office for National Statistics, which said that there are no deaths between 2018 and 2023, which even reported as a factor. There was an article in the Times of London a couple of months ago, which was entitled "How the Health Food Store Drug Kratom Almost Killed My Son." It was written under a pseudonym. And it said, look, in the UK, you probably don't even know what this is. But in the US, you can get it on health food stores, vape shops, convenience bodegas. And this is a very strange situation where clearly in the UK, it's banned. But in the US, it's in a much more grey area.
Yes, absolutely. It is widely available in most parts of the US. And we can talk a bit more later or when you want about the policy landscape. But federally speaking, there is no, overarching rules, regulations around this product currently. So different states and then local municipalities are taking different actions as they are seeing the harms. So in certain states, there are bans or specific regulations related to the product. So at this point, it's really a patchwork across the US. But still in many places, and Michigan is one of those, it can be purchased in all of those places you mentioned, no age restrictions whatsoever. So yep, in the gas station, in the vape shop, in the convenience store where people are, accessing other safer products as well. And these are right alongside those.
And so if we might start at the very basics, what effect does Kratom have on a person who takes it? Why might someone seek it out? And how do most people who you see who are struggling with its use begin using it in the first place?
I guess just to start on sort of what is Kratom and specifically also what is sort of 7-OH or 7-hydroxymetragenine. And I'm going to lump them into two separate categories. There are a whole range of products on the market that sort of span these two, but I'm going to I'll lump them for the purposes of our conversation. So starting with just Kratom and sort of what people will call the natural leaf Kratom, Matt, that you reference has been around, used medicinally for many, many years, generally without a lot of risk and harm associated. So that natural leaf Kratom product has many different alkaloids in it, or you can think of it as like ingredients in it, right? There are three primary ones that really act on the brain that offers the relief that people are often seeking these products for. So I'll talk about those three. So one is what we call the serotonergic system. That's the part of the brain that boosts the mood, right? So when people are looking to use these products to enhance their mood, it's the serotonergic system that's really acting. There's another alkaloid that works on what we call the noradrenergic system. And this is really our energy system, right? It helps people with boosting their energy, boosting their focus and their attention span, right? Something that most of us need help with these days. And then thirdly, the one that is getting the most attention is the alkaloid that is working on the opioid part of the brain, right? So this is the same place that heroin, fentanyl, morphine is working. That is the metragenine or mitragynine, depending on how you want to pronounce it, and 7-hydroxymetragenine or 7-OH. So in that natural leaf Kratom product, there's only about 1% of that is that opioid-acting portion, that metragenine or 7-OH component. So that's sort of the traditional product that a lot of people at least started using that's been around in the US since, around 2015, something like that. Then we fast forward to really what we're seeing now. And since about 2024, 2025, we've seen an explosion of these synthetic products that they're not all called 7-OH, but most of them are 7-OH type products, or they might be sold as like a Kratom extract. These are sort of like super powered on that opioid impact. So the 7-OH products tend to be about 15, 20 times more potent, meaning stronger than morphine in the way that it acts on the brain, right? So this is acting very traditionally like another opioid, like fentanyl, morphine, heroin on people's brains. So there are sort of these two main buckets of products. And I think what gets really complicated for consumers and clinicians alike is how are these differ? And then how does anybody know which one they're getting, right? And, I like to think about it like coffee because I can't survive without my coffee. You could order a coffee and that could mean, it's a light, watered down, regular coffee with a splash of milk. Or you could get a coffee and that's a quad shot mocha latte with whipped cream, 6 shots of added sugar, right? And that's also coffee. And the effects of those two types of coffee on the body are extremely different, right? And if you don't know which one you're getting, that's a decision you want to be able to make as a consumer of which of those you're getting. Similarly, right now, people have no idea really, are they getting that natural leaf product, AKA that watered down coffee with milk, or are they getting the supercharged one that's going to have that strong opioid effect like the quad shot mocha latte?
So one of the nicknames I've heard that the Kratom has is gas station heroin.
Mm-hmm.
That sounds maybe a bit of an oversimplification.
I think yes and no. I will actually say that a number of patients who have come to me seeking care are people who have used opioids in the past, like heroin, and they will say that when they started on these 7-OH products, it felt just like being back on heroin, like within a week or two. So they very much would say this feels exactly like gas station heroin. And again, that tends to be more that synthetic concentrated product, not that natural leaf kratom product. But for many of my patients, they actually thought they were using that natural leaf kratom product, or maybe they had been using that product pretty effectively for a while. They went into their usual convenience store or vape shop, and one day the person said, hey, here's a free sample of a better version of that kratom product. And that was 7-OH, right? So a lot of them got accidentally exposed to this super powered version when they thought they were getting sort of this, more traditional natural product.
And so if the effects of 7-OH are super powered compared to natural leaf, then are the adverse effects similarly super powered, especially the potency for dependency?
Yes, absolutely. So people who are using 7-OH will tend to develop an opioid-like addiction. So what does that actually mean? That means they are tending to need more and more doses by the day to be able to feel the same effects that they were getting previously. So that we call that building a tolerance. We also can see that people can experience an opioid overdose, right? And that can be fatal. So it suppresses the respiratory drive. We can also see that will then produce withdrawal symptoms if someone suddenly stops using it or has it taken away from them. And those withdrawal symptoms are, again, very classically opioid withdrawal symptoms. So people feel tremendously restless. They get goose flesh on their body. They feel nauseous. They get cramps, aches all over their body. People describe it as 100 times worse than influenza. And so people will develop that exact syndrome with the 7-OH products, just like we see with heroin, with fentanyl, with other more traditional opioids.
And so to treat those symptoms, does traditional evidence-based treatments for opioid use disorder apply to these products as well, or are there specifics that must be taken into account?
So again, for the opioid component of this, absolutely the medications that we use to treat opioid use disorder are extremely helpful here. And the one really at our disposal primarily here in the US as an outpatient practicing physician is buprenorphine, also called Suboxone. And we know, in people with traditional opioid use disorder that we've studied for a long time, that medication reduces the risk of dying of overdose by 50% or more on any day someone takes it, right? So really powerful, really effective medication. It manages withdrawal, it manages cravings, and it can be protective against an overdose. Wonderfully, that medication is extremely helpful for the opioid-like effect of 7-OH or Kratom. So again, that means it will hold off the withdrawal symptoms, it will help with the cravings and keep people stable in that way. What's a bit more complicated though about these products is there are those other ingredients that we talked about, right? The noradrenergic system, the serotonergic system. So in some ways, my patients say it almost feels like taking 3 medications in one or 3 drugs in one, an opioid, a stimulant, and like a serotonin medication, like an SSRI. So the medications we have to help with the opioid effect don't help those other pieces as well, right? So as we're trying to help people transition off of this, we can help that opioid withdrawal, but we often need to think about those other effects, like how is their mood and how are they going to manage coming off a medication that was helping their mood or helping them with their energy and their focus as well.
So this is a very strange situation to me, that there's this substance where there's no sort of standardized dosing of it. There's no standardized form of it. You could buy it in the garage. It seems to sort of affect different individuals differently. I mean, when you've got that kind of a confusion, what numbers do we have? Do we have any sort of good epidemiology on use and how many people have problems with use and how mortality, morbidity statistics? Is it possible to even collect that in a reliable way?
Great question with a pretty unsatisfying answer, which is we really don't have reliable information. So lots of estimates out there, and that might range from anywhere, depending on what you look at, maybe 5 to 15 million people who are using Kratom-related products in some way, right? Again, and that's the whole range of products. We don't really know which was which. We don't know the rates of mortality per se, because again, first of all, we haven't been looking for it for very long. And measuring it can be tricky. So, when people are doing autopsies and things, they haven't been looking for it for that long. So again, we don't truly know. There have definitely been deaths recorded that have been related to those products, but we also aren't always sure, are there other substances involved as well? So there is not clear data in that way either. And then in terms of progression to something like an addiction, we also don't know. There's a lot of new research coming out quickly, but again, it's really hard for science and rigorous science to keep up with the drug market the way that it is currently. But one that I just read was that of all of the people using 7-OH, about 70% of them meet the criteria for an addiction. So very high rate. And again, that's with those potent synthetic products. So the answer is we don't have great information at all. And that is part of what, at least regulating these products would allow us to do better research and truly start to spell out what are the risks, what are the benefits from there. But right now we're kind of operating blind.
So, Liza, that's an answer which has both clarified things and left me more confused. I wonder if there's any particular demographic. Is it younger people, younger men? Who tends to use this substance?
Yeah, so it is so far in what we can see a bit more male predominant and does tend to be younger folks as well. A lot of people have a history of another substance use disorder in the past, or at least report using some kind of substances, right? So about 90% of people, 95% of people who are using a Kratom product use alcohol in some way. Doesn't mean they have an alcohol problem, but report using it. Very similar with cannabis. And then there's a good portion of folks who have a prior history of an opioid use disorder, again, sort of fentanyl, heroin, one of those more classic opioids, who are using it currently and sometimes as a replacement or a substitute to avoid using those more dangerous opioids as well. And then also higher rate of people with mental health challenges and chronic pain. And again, that sort of goes back to the way that that Kratom works on the body, and that people tend to be seeking relief from symptoms like chronic pain, other opioid withdrawal, their mood, that sort of thing. So that's who we tend to see using it. But again, we don't have perfect information about that.
And is there a typical trajectory that you see for people who begin using 7-OH? Does it mirror opiate dependency? And similarly with health effects, just doing background for this podcast, many people who use natural leaf kratom seem to be able to do so for extended periods of time without necessarily experiencing acute adverse effects. But with 7-OH, obviously, it's a different story.
Yes, absolutely. So again, this is less from large research and more from anecdotally what I'm seeing in patients. So that is a certain sample, right? I'm seeing mostly people who are here who are seeking care because they've developed a problem. So that's my lens. But generally speaking, you're exactly right that people if they really are using that natural leaf kratom product, again, only about 1% of that has that opioid effect to it. So people need to be using a lot of it for a very long time, very frequently, to develop an opioid addiction type syndrome. And I have seen that, but it takes much longer and tends to be much less common. On the flip side, those concentrated, synthetic 7-OH type products, those are the patients where I'm seeing even just a couple of weeks of use with that. People are escalating their doses to the point where they're spending a couple $100s a day, really within several weeks of use, and having those opioid withdrawal symptoms if they stop, right? So physiologically, their body is changing rapidly and developing that tolerance in many ways, even faster than sometimes more traditional opioids, but at least as fast. So those trajectories, yes, are very different if it is sort of that natural leaf product versus the synthetic product.
Yeah, Liza, it's my experience that there's no sort of single story, no single route by which someone ends up with a substance use problem. But just to skip back to what you were saying earlier, that this isn't just the opioid, it's also the noradrenergic, the serotonergic. To what extent is this a form of people trying to sort of treat themselves for something because they don't have access to, say, mental health care or a good pain clinic?
I think this is one of the most important points actually about the Kratom conversation, which really goes beyond Kratom, right? You hit the nail on the head that this is a lot of times people trying to manage symptoms that they're experiencing, right? People are suffering in various ways. And whether it is that they can't access the typical medical system, again, unlike in the UK, here we have a lot of folks who don't have insurance and can't access the medical system. I think it also speaks to there is a lot of mistrust in our medical system, and some of that is well-founded as well, right? So people are sometimes, specifically avoiding going to see, sort of a traditional Western medicine doctor and choosing to self-treat with other medications instead or other substances. And I think it also kind of speaks to the movement that we're seeing generally of people wanting to maybe move a little bit more towards something that's perceived as natural, herbal, even though, again, a lot of these products are no longer natural and herbal at all, but they are still marketed that way. So people wanting to lean toward that versus like a traditional Western medicine. And then absolutely lack of access to things like mental health care. We don't have great care for people with chronic pain in this country, right? And we took away opioids previously as a medical community. So that left a lot of people struggling. So I think Kratom just shows us there's this huge set of unmet needs that are not met either by our medical system or by our society. And what I think is important to consider is if we do as a country or as states, remove Kratom from the market with our policy, all those problems are still going to be there. And if we don't meet them as a society, we know the market will sweep in and meet them just with another new substance, and it'll be something new tomorrow. I think it is really important to think about those root causes and be thinking about how do we address that versus just sort of whack-a-mole of a new substance as it comes onto the market.
Well, so along those lines, as local regulations are being debated, and currently in your state, Michigan, the Senate is in the midst of debating a prohibition bill that was just passed in the House. What kind of regulation would you like to see, and what do you think would be most beneficial to populations affected by Kratom?
So this is the $1,000,000 question, and not an easy one, of course. Any policy, specifically any drug policy, has unintended consequences to it. And my expertise is certainly in clinical medicine, addiction care, not policy design. So I don't have the perfect answer. I think the best path forward here is really an approach that is collaborative, right? Scientists, clinicians, public health experts, policymakers, people with lived experience, trying to put together the package that's going to have the most benefit and the least harm. From my clinical perspective, though, without a doubt, we have to have some kind of action. Our current state is not okay for the health of our communities. We can't be ignoring a really unregulated market where people have no idea what they're actually taking or any of the risks that come with that. But at the same time, as we've already talked about, I think we need to be humble and nuanced and anticipate the unintended consequences of any policy that we make. So, for example, if a full ban is passed, we have to understand and prepare for the fact that people will have sudden, untreated pain, low mood, low attention spans. People will be in opioid withdrawal. And without a plan for that, as I talked about, a bunch of those individuals will probably just turn to more dangerous substances like fentanyl or whatever shows up in the gas station the next day. But at the same time, of course, if we do nothing at all from a policy standpoint, then a lot of people remain unprotected. So I think at a minimum, we need product testing, labeling, limits on misleading health claims, and more monitoring of the high potency products, and certainly more research so that we can develop an understanding really of what the risks and the harms and the benefits are. And ultimately our goal should be, to reduce harm as much as we can without oversimplifying a really complicated issue.
Yeah, this reminds me of given this quote on another podcast as well, so apologies if you've heard that, you're going to hear it again. There was a professor who specializes in psychosis here in the UK. He, a few years ago, became very interested in the link between cannabis and psychosis. And I went to a lecture of his a while back, and he was asked a question about the potential changing legal status of cannabis. And he said, look, the legal situation is one thing, but to my mind, the bigger thing is a lack of education meeting the worst of rapacious capitalism. And it sounds a little bit like that's what we're talking about here.
Yes, I think very parallel. It's a quote worth repeating. Absolutely. Yep. And I think, again, this speaks to, first of all, a lot of people are now getting their health information or their information in general from various, whether it is social media, any sort of digital device that's giving them information. That's often where people are learning and sharing experiences. And at the same time, we have this, incredibly unregulated market, and people are able to make money off of, other people's suffering and couching that as trying to help them. And so again, whether it's in convenience stores or whether it's buying things online, it's tremendously hard to regulate. And so capitalism is indeed going to, meet the demand that we aren't able to meet as a society otherwise.
And then stepping back a moment to the clinical side, what kind of research would you like to see that you think might best inform these future policies to help get a handle on the more health-oriented aspects of the problem?
So many questions, but I think, three main buckets I would think of as, first of all, epidemiologic. Again, we don't truly know how many people are using these products and which of these products they are using. We don't have a great sense of the true risks. Again, like mortality data, we just really don't know. So that epidemiologic piece is absolutely vital. And then sort of on the clinical side, thinking about, more understanding for why people choose to use these products, what the clinical effects are of different formulations, different doses of those. And then really moving to the treatment arm of if people do develop a use disorder related to this, what are different effective forms of treatment? What are people's pathways into treatment? And what are people's barriers to treatment? Because there are enormous barriers to all addiction treatment in our country that absolutely apply here as well. So really thinking about, as a medical community, what are the ways that we can step up to help meet the need for folks who are already struggling with a use disorder related to these products?
And what advice might you give to someone who thinks they might be developing a dependency, or someone with a friend or family member who has been using Kratom or 7-OH and is exhibiting, that behavior of concern?
So I think, first of all, relying on whatever relationship you have with that person. And it's, wonderful that they have somebody who cares about them is important. And in any of these conversations, of course, being concerned about someone, making sure you're offering, compassion and listening as well as offering information. Remembering that embarrassment and stigma is such a potent force within all substance use disorder and really dissuades people from sharing, from seeking care. And I will say the stigma people using Kratom, I think, is even a little bit different than with other typical substances, in the sense that I've had a lot of patients who express feeling really embarrassed that they got stuck on what, is like an herbal product, and they don't realize that other people have developed that same dependence. They feel like they're alone in it, and they feel embarrassed that they did it with, some herbal product that was supposed to be healthy and natural. So I think there's this extra layer there that might keep people from seeking care even more so than, somebody who, is going out to a street corner getting fentanyl and sort of knows that that's a problem for them. So just being aware of the stigma that people will be experiencing around this, and then reaching out, to a healthcare provider. And not all healthcare providers know exactly what to do to help at this point. And that's a lot of the work that I'm doing across Michigan, is providing education to other physicians, other healthcare providers in how to help. But at least starting with, whether it's a primary care physician or an addiction care physician, just to begin the conversation of what the options might be. And for people to understand that there are a lot of other folks struggling with this same thing. So they're certainly not alone in that.
Okay, and if I were a primary care physician listening to this podcast, I think I'd be quite worried, because it sounds as if there's a lot of, to return to the theme, I think, a lot of confusion, a lot of misinformation around. Is there a source of information I could get as a primary care physician that would help me to help the patient? What would be my first moves clinically in terms of thinking about the problem, in terms of referring to secondary care providers? What should I do under these circumstances?
Yeah, absolutely. And, if you're a primary care physician here, you probably have 15 minutes with the patient to address a lot of things. But I think, first of all, with the patient themselves is, number one, exploring again sort of the severity of their use and how that's impacting their life, right? Is this sort of, just the beginning and dabbling, or have they actually, developed a use disorder? And that might change a little bit how rapidly and aggressively we're going to try to tackle it. Trying to understand the reasons why someone is using is so important. Again, is it that they have pain that isn't otherwise managed? That's something we can help with as primary care clinicians. Do they have a low mood? We can help with that. Are they trying to avoid other opioids? We can help with those pieces. So really trying to understand why the patient's using those. If they do have a pretty severe use disorder and they need help coming off, offering that buprenorphine care, which is something that any primary care provider, any provider with a controlled substance license in our country can offer buprenorphine care, although many do not. But being willing to do that with a patient is going to be potentially life-saving for that patient. And we do, within Michigan, I run a lot of trainings about how to provide buprenorphine care. And most states have ways to learn about that more. So those are kind of some specific pieces to explore with the patient. Often now there are local, different addiction, like Kratom addiction organizations that can offer some of that psychosocial support or peer-related support that you might be able to connect the patient to as well. And then, if you happen to be in an area where there is an addiction medicine clinician, you certainly could consider working with that person or referring the patient to that person who may be able to help as well.
And for emergency responders, if they should find someone suspected to have overdosed on 7-OH, does naloxone work in the same way it reverses opioid overdoses?
Yes, great question. And I'm going to again say yes and no, which is the theme here. So naloxone will reverse the opioid-like component. So when most people say overdose, we're thinking in our brains typically of an opioid overdose, which means essentially that the person's respiratory drive is suppressed and they stop breathing, right? So it's the blue lips, unconsciousness, not responding, not breathing. So in that scenario, yes, a naloxone will reverse that overdose and wake that person up and get them to breathe again. However, like we talked about, these products have all of those other components in them as well. And there are other ways that people can have, quote, an overdose or die from these, such as having a seizure, having a severe liver injury. The naloxone will not help with those components. So if someone, of course, were having a seizure or something like that, that would just be calling 911. But if the breathing has stopped, by all means, then using the naloxone and calling 911 anyway. Or if you are 911 and you're an emergency responder, providing the additional care you would typically provide.
And among these 7-OH products, I know there's no standard formulation. Are the concentrations relatively standard across 7-OH, or even within that, could it have a greater serotonergic effect and another batch might have a greater opiate effect, whatever is there that much variability as the same way that there is within the larger product spectrum?
Yes, there is. We believe there is. Again, there hasn't been a lot of rigorous testing, so we don't totally know, but very much so. And I've had patients tell me that even within the same product line, they might be using their typical amount and then it feels different to them a different day. So absolutely, I think it's impossible for anybody to predict what are they actually getting when they get any of those packages, even if it looks the same as what they got the day before.
Well, thank you very much. I think you've answered all of my questions that we have the information to answer at the moment. Is there anything else that we might have missed that you would like to communicate about Kratom to our audience of clinicians, or just the general public, or anyone who might be perusing the behind the counter at their local gas station and curious about? Because I assume they're not labeled always as Kratom or 7-OH, right?
They do have different, usually you can find those words somewhere on the package, but it may not be called out. It may be just like labeled super energy booster, that kind of thing. And if you haven't yet, if you have a chance and you're in the US, like go into one of these shops and look for them. And the newer products, even they might be like grape flavored, right? They look appealing even to children, which I especially know because I have a 6-year-old. And when I'm putting together presentations with these images, he thinks they look like delicious candy. So they really, yes, they are not always clearly labeled to anybody. So there are a lot of people who may use them and not have any clue what they're actually getting. So that, very important for consumers to know that. And then, I think the other piece I would just add, and we've alluded to this a lot in terms of unintended consequences, but I think, we really can, and I think a lot as a medical community, we reflect back when we suddenly mostly stopped prescribing opioids after we had been over-prescribing them for a long time. I think we can draw a lot of lessons from that when we're thinking about how we're going to write policy on Kratom, right? And what we did as a medical community was with opioids is we realized there were immense harms happening and that was real and we needed to change course. But we did it in a sweeping, rapid way without planning for the unintended consequences, meaning all the people who were going to rapidly go into withdrawal and suffer severe pain, mental health conditions, and sometimes start using fentanyl or heroin or commit suicide in the worst cases of scenarios. So I think as we are doing this, a similar consideration here with these products is we have to remember what happened when we did that with opioids And again, if we are going to make sweeping policy, we have to make plans to help the many people who are going to be affected by that. And I think at this point, at least speaking for our state, but I think nationally, I don't think we have the systems in place to readily support the people who are going to need help. So that really, to me, is the vital part of the conversation that we have to remember as we're working for policy.
Yeah, because drugs are never just drugs. And it's not as simple as saying we'll just stop people taking drugs, because they are the sort of visible part, often I found, of deeper problems, deeper medical problems, mental health problems, social problems. They're almost the indicator of it. As well as being an issue in themselves, they are an indicator of other issues. And I think unless you get that, you never really begin to address the deeper problem.
Yep, absolutely, 100%. Yep, you can remove today's supply, the demand will still be there. And as we said, the market will meet it.
Well, thank you again for joining us, Liza, and good luck with your work and expanding awareness about the dangers and susceptibility of the general public to these supplements of concern. I don't know, Niall, is there anything else you'd like to add?
Just to thank you again, Liza, for joining us. And also, as ever, we'd like to thank the listener for listening to this podcast. We hope you'll join us again next time. But for now, goodbye.
Thanks for listening to the Lancet Pulse. If you enjoyed this show, leave a rating or a review on your favorite platform and subscribe to stay updated on our latest episode. The editorial team includes Chloe Wilson, Ben Abbott, Matthew Gilbert, and Jonathan Pym. This show is part of the Lancet Group podcast offering, and it's produced by Matteo Simonetti. Thank you for being with us.